what we have the scientific support. So we have to be sure that we know what are the scientific criteria to say, look, my implant is a success. So Abelson in the year 86 defined that every implant should be an attached implant is immobile and with a tested clinically. The radiography doesn't show any sign of peri-implant radiolucency, and also there should not be any kind of vertical bone loss after 1 year of service, and it includes 1.5 millimeters of bone loss during the first year. Please put this number in your head, 1.5 millimeters of bone loss during the first year. This is very important for what is going to come next. Also, to have success with an implant treatment, there should not be infections, no pain, no neuropathies, no paresthesias, no violations of the mandibular canal, of course. These were written in 1986. So, in the context of that, 1986, what the success rate of at the time was 85%, and a 5-year period it goes down to 80%. We know that these numbers nowadays with the new innovations of the implants, this is not quite the most suitable number, also accurate. So let's see some things that we should know before we move forward into the blood, into the surgeries. Is that in every implant and in every teeth we have a biological width, that it is quite similar. Why is it quite similar? Because both of them, they have a connective tissue and 2 millimeters of epithelial attachment. This connective tissue in measurement measures almost the same, 1 to 1.5. And also, there is, in the teeth, there is collagen rich, but with less cellular content, you know, in the implant. So we will see that in the implant, the biological width is much more a scar that has less cells. And if it has less cells, it will not recover so well as a teeth. That's the big difference. It is also not so well irrigated by a blood supply as it is a teeth. That's the big difference between the teeth and an implant, and also the orientation of the fibers that go around the implant and the teeth. We have some fibers that go parallel to the implant, but these fibers go oblique to the teeth attachment. That's why the attachment between the bone and the teeth and the periodontal is much more reliable than the one that we have in the implant with the bone and the peri-implant soft tissue. So there is also another explanation that I would like to give to you regarding this article, because it's very important that we understand the 1.5 millimeters, where it comes from. So we are going to this article from Ericsson in 1995. This animation where it explains what happens after we place an implant and after we place a healing abutment. This is very important that you understand that after placing an abutment that is extraorally exposed, there will be a gap between the healing abutment, that is you see the healing abutment on top of the implant, and then now you see some yellow spots here. These yellow spots are bacteria. These bacteria, they are going to start contaminating this gap that is always present between the implant and between the healing abutment. So what is going to happen is that the connective tissue and the surrounding tissues, they are going to stay away from this zone, inflammation zone. And that's why there is going to be a resorption after we place an implant, what we call the sulfurization. Yeah? That's why it's very important you to understand this, because this X-ray is one of the most important in the modern implant dentistry. It was from the article from Lazareva in 2006, where he placed wide implants, but instead of placing the healing abutments for that implants, he placed more narrow healing abutments into these implants. And what he observed is that the implants where there is not a match between the width of the healing abutments and the implant, there is much less bone loss. And they start to call it the platform switching. Platform switching is nothing more that we shift away the gap towards the internal part of the implant to avoid that the bacteria that contaminate the gap are too close to the bone. So some other authors try to do this platform switching concept, applying it to tissue level implants, but well, the results on short term, it was okay, but always on thick biotype. This is the case of Canulo 2007. But one thing that is very important and we have to understand is that we have to know what implant system we are using. If we use an implant system with a machined color, for example 1.28, that is the Straumann, the tissue level, we know that we can put it supercrestally, crestally or subcrestally. But the closer is the gap between the implant and the prosthesis to the bone, the more bone resorption will occur. This is what is explained in this animation. As you can see, in the left side, the implant almost doesn't have any bone loss. And on the right side, much bone loss because the implant is completely subcrestally. But there are other things that may explain why we have much more bone loss in one implant than in others. And this one comes from Abramson in '96 and also from Linkevicius recently in 2013, where they stated that patients with thin biotypes, they will have more bone loss. Why more bone loss? Because the implant needs a biological width that, remember, has to measure 3 millimeters in total, like in a teeth. So if we have a thin tissue of 1 millimeter, you have a bone loss of 2 millimeters for sure. If we have a thick mucosa and the biological width can be built around that thick mucosa, what is going to happen is that bone remodelation around the implant is going to be much less than the bone remodelation that you can expect in implants with a thin biotype.